amount of time, and we want to do our best to keep things moving. So, Melanie, back to you.
Yeah, I'm actually going to turn it to Anena to do the opening comments today.
Thank you, Melanie. Good afternoon, everyone. Thank you for joining today's subgroup discussion. We would like to remind everyone that the meeting is being recorded. Please contact the MHCC team with any technical issues. We sent an email earlier with the team's contact information. As a courtesy to others, please remain on mute when you're not speaking to reduce background noise. Staff may mute you if there is a lot of background noise coming from your line. You can also mute and unmute yourself using the small button at the bottom of your screen that looks like a microphone. We have a brief presentation this afternoon. Please hold all questions until the end of the presentation. At the conclusion of the presentation, you may raise your hand by clicking the raise hand button under reactions at the bottom of your screen. Another option is to enter your question into the chat box. The meeting facilitator will sequence speakers and may also call on people to speak to ensure that we have a wide range of perspectives. If the speaker is not able to answer your question during the meeting, the speaker will respond via email after the meeting. So before we begin the meeting, I would like to recognize the work group members who are attending today. We have Ms. Sally-Ann Alborn, Dr. Jeffrey Bernstein, Tyler Blanchard, Dr. Sarah Johnson-Conway, Matt Ramnathan, Christina Kaminsky, Senator Lamb, Dr. Russell Lewis, Dr. Joe Masteller, Mr. John Miller, Ms. Terry Sano, and Ms. Laura Russell. Is there anyone I have missed who would like to introduce themselves?
Christy Simon Waterman from Maryland Nurses Association.
Thank you, Dr. Waterman.
Nora Hoban, Mid-Atlantic Association of Community Health Centers.
Thank you, Ms. Hoban. I think that was it, David. I'll turn it back to you.
Okay, well, just a couple remarks. Our executive director and chair, Mr. Stefan, he will be joining us shortly.
David, I think you're on mute.
I see that. It's Monday. So good morning, everyone. Thanks for joining us today. We have a full agenda, so I'll just recognize the many participants who've joined and thank you all for joining. We anticipate our chair and executive director, Mr. Ben Stefan, to join us with the meeting in progress. He sends his regards and looks forward to getting with this group as we proceed over the next hour. So back to Melanie for taking us to the next step.
So at this time, we're going to review a very slide. Mary Jo is going to, our consultant is going to look over it and talk to you about kind of where we are with this process. So people can know we sent out the list of framing questions and people sent responses. So what we're looking for is some people would like to know kind of where we're going to go with that. So I'm going to turn it to Mary Jo to walk through the slide.
Great, thank you all so much. Just to do a quick introduction, my name is Mary Jo Condon. I'm a principal consultant with Friedman Healthcare. If you go to the next slide, we just have one slide this afternoon, so it'll be a quick one. As Melanie mentioned, we want to sort of tee up how the framing questions and those responses fit into the rest of the process. So you'll see at the top there, the framing questions were shared with the work group members and those responses were received. And as we look through those responses, it really helps us think about what is that vision for primary care in Maryland that the work group members sort of see in their own minds. And what we're going to be talking about today is really thinking about how we take that vision and how might we measure progress towards achieving it over time. So we're going to spend most of today digging into a set of potential measures that would help us measure progress towards the vision that has been outlined. Next, we will draft a primary care investment definition that reflects that vision and get your input into it, identify the resources necessary to achieving it, And then really this last piece occurs over a lot of time, right? Sort of continually measuring progress towards access and quality and cost and investment goals, and seeing, how are we doing over time? And we expect that that would be a continual and iterative process. Any questions on that? All right, hearing none, unless Melanie and David, anything you wanted to add?
No, I think you've summed it up nicely, and I think we should just proceed.
So I'll just kind of tee up what's going to come next. So at the last meeting, we began to review a table that shows the measures that we were talking about and some potential sources for those measures. So what we're going to walk through today, and Mary Jo is going to walk through the table setup, but basically these are things we could be measuring based on those pillars, and what would be the source for those and what would be the rationale. And then we'll be asking for your feedback on how important do we think this particular measure is, and just any other feedback you may have on each of these individual measures. So with that, I'll turn it back to Mary Jo to walk through the table, measuring progress towards primary care goals.
Thank you, Melanie. Appreciate that. So wanted to, basically what we're going to do today is we're going to walk through each of these operational elements. And to give you a sense of where we started, we started by just sort of brainstorming what could be an approach to measuring progress towards this particular operational element. What type of data might we use? What might be the specific source for that data? And then we sort of built that out to be more specific. So including there in column F, what are sort of examples of the data measures, or for example, in this one, it's a survey, so the specific questions. And then going even more granular and naming out what are those questions or what are those field names, and then providing a rationale. I know that this has been provided to all of you, and so I'm not going to spend too much time on some of the columns, but rather really focus today on 3 columns. So one is just the operational element, just to sort of set up what are we talking about here. And then 2, the source. And then 3, the rationale. And after we sort of go through those, we'll talk a little bit about, do we think this is a high impact or not as high of an impact? Another way we might say this is a must have or a nice to have. And I just want to set this up by saying, as many of you may be aware, there are a lot of efforts, 3 or 4 that come right to mind that are occurring nationally and within states to think about how we measure progress towards our shared goals for primary care. And so while we want to make sure that we're moving forward here in Maryland and not sort of waiting for others, we also want you to know that we're going to be continuing to crosswalk those national efforts and other state efforts with what we're doing here in Maryland to see where we aligned, where might there be some additional opportunities. All right. So with that, let's start with the first one. So the first operational element is modality. And this is essentially, how is that patient interacting with the primary care system? Is it in a face-to-face office visit? Is it through a telehealth visit? Is it a phone call or a text? There's a couple of different examples that we brainstormed here. One was to use the CAPS clinician and group survey, and specifically a few of those questions related to whether or not the visit was in person or by phone or video, et cetera. That's the first. And what I really, if we go to the rationale, what I really sort of liked about this approach was that it didn't just have questions on how did the visit occur, but also in some ways from the perspective of the patient, whether or not the visit was a success from a modality perspective. It asked the patient things like, were you able to easily understand or use the technology system? Were you able to get the video working? Were you able to hear? Essentially, how did that communication go? And so I think of this as pretty high impact because not only are we understanding the modality, but also from the perspective of the patient, the success of that modality. I'm going to do just the other modality one, and then we'll stop and we'll sort of pause for some discussion. So the next one is define primary care services. Basically start with what is going to be our universe of primary care services, and then look in the claims and specifically in the place of service code to understand what proportion of these visits occurred in the office, what proportion of them occurred via telehealth, what proportion of them perhaps occurred at a retail clinic or an urgent care center. So that's more of a claims-based approach, the first approach being more of a survey approach. I think these are both useful to understanding modality. I think, though, as I mentioned, what I really like about that survey one is that you do get that perspective of the patient on its success. What I really like about the claims one is that it, it comes out of something a bit more concrete than the survey results. So with there, I'm just going to stop for a minute and see if we have any questions on that one, if that sounds good. If anyone has any concerns.
Dr. Bernstein has a question. Dr. Bernstein, go ahead.
Yes, thank you. Yeah, a couple questions, concerns, and I guess one of the reasons I'm sort of pediatrician, and I have some concerns that some of the tools that you're talking about won't be accurate and inclusive for the broad range of what I think we're trying to accomplish, including primary care. CAP survey in particular being an adult interaction-based tool that I don't think has applicability to, limited applicability to non-adult primary care, or maybe even not applicability to non-Medicare primary care. I think we're missing a lot of the range of what we're trying to tackle here. And I guess the other thing is I don't really understand how place of service in a claims is a marker for who's doing the interaction. Those seem to be two different things to me. So I'm
Sure. So
not following.
Great questions. Thank you so much. And the first thing I'll say is I think, as we all know, as we sit here, the data sources that we have available are not always ideal, right? So we're often sort of, taking what's available and trying to figure out what we can glean from it. That being said, Dr. Bernstein, are there other survey tools that are widely used in the pediatric community that you would ask us to look to?
I'm not aware of survey tools to get at that particular question. In fact, it would seem to me that's if done correctly, coding should indicate the mode of the visit better than even survey, because the codes are specific for the mode of the visit.
That's right. And in fact, that is that place of service code. So telehealth has a place of service code of 2 or 10. Place of service codes exist for office visit and retail. And so for this specific question, we were trying to get at the modality rather than the individual or the type of specialty that delivered that. So yes, you're absolutely right. We can use coding for this, and we can use that across populations.
There are modifiers for the modality, telephonic versus audiovisual. So it's not just place of service. It's
correct. The GT and the yes, very true. And so I'm seeing some other folks in the chat that agree that coding would be more appropriate. David, did you want to call on additional folks, or did you want me to?
So
So-
sure. Why don't we start with Jill, and then we'll go to Dr. Dr. Conway, Dr. Marcella?
Yeah, I just wanted to clarify, are we shooting essentially for one measurement for each of the concepts? Or do we, will we consider more than one measure for a specific concept? I appreciate what you've said about the survey giving us some impression of how the patient felt about that modality, which I think is helpful. But I agree that it's not going to cover everybody. And my thought is that claims, we try to always go to the best or the most reliable source for that it involves the least burden to get information. And it feels like the claims data are the way to go in terms of best accuracy. And you guys already have access to all the claims data and so on. So, I just wanted to see whether, we are interested enough in the patient's perspective on it that we want to have more than one measure.
And Dr. Marcella, and to Dr. Bernstein's point, I think the answer is you're both right. We have a place to start, and there may be some value in getting perspective from the consumer, if you will, the patient. The claims data is a rich source of information as well. So if there are other areas or units of measure, please feel free to share them with us as we go through this. I don't think necessarily looking at the measure today. We're trying to get a sense of, are we on the right pathway, if you will.
Yeah, that's what I was going to say, David. I don't think we're looking to get to one measure, one source for each measurement type. I think we could have multiples depending on if they all seem to be reasonable.
Yeah, that's right. Dr. Conway.
Thanks. I think, just acknowledging that no measure is perfect, right? So I think you have to look at multiple measures to really understand the whole picture that you're getting at. One of the things that I just was struck with, and maybe part of it is just acknowledging what the measure can't tell us. When you're looking at this modality and you're looking at a claims-based measure of defining primary care services, it assumes that those primary care services are something that is captured in a claim. And so I just think it's worth sort of acknowledging that, and we haven't gone through the rest of the measures to say where else that might be captured, but some of the things that we do today that are primary care services, like replying to patient messages or doing other things that have no billable capability associated with them, but are very critical aspects of access and connecting with patients, is not included in a measure of that nature. So not to say that that's not the right measure to be using, but I just think it's important that we understand that there's a lot of other immediate same day touch points or other things that might occur with patients that are not captured within that.
Yeah, and I think the commenters tend to agree. So why don't we press onwards? Mary Jo.
Absolutely. So Dr. Conway, this is a great point that actually comes into play a lot in this next piece around the personnel involved. So this is looking at who is the provider that engaged with the patient. Was it a physician, a nurse practitioner, a nurse care coordinator, another team member? Again, we can use claims to understand this at some level. But if you go over to the rationale, I put sort of a note at the end of this that it's important to note, I think, that the claim does not always reflect the provider who actually rendered the service. And so while I do think that this is probably at this point our best source of data to understand the personnel involved, sort of echoing Dr. Conway's point, it's true that the claim does not always fully represent that. I believe that there's a question in the chat that I'll defer to the MHCC folks on as to whether or not there's access to data through CRISP.
Yeah, I think what we do is we just note this is a good point, because sometimes the answer is more, it's longer than it's simply a yes or no. But I think we should just note the comment here and keep moving, if that's okay. Dr. Marcella, any concerns? Okay, thank you.
All right, excellent. The next one relates to first contact. And so in this case, using a claims-based approach, using the APCD as the data source, Essentially, what we would seek to do is to look back and see whether or not or calculate the proportion, I should say, of the services that were delivered by the same healthcare professionals or healthcare professionals in the same team. And so, ideally, there would be a provider directory in place that included organizational affiliation to allow for a little bit more accuracy and completeness in this. That being said, this could also be achieved using the billing provider ID and the practitioner tax ID to understand when services were rendered by providers that are working for the same organization.
Any reactions from the group? Okay, very good.
All right, let's go on to the next one. And this is really looking at conditions or situations when it's appropriate to approach primary care as the first place of contact. And I think that, our primary data source for this would be the APCD and looking at claims, but I also think it's important to recognize that this also requires some consultation with the literature and with stakeholders to really identify those diagnoses that could be more frequently treated in a primary care setting. So this would involve looking at the diagnoses on the claims for office visits and other services, and then looking at patients for whom the visit or the service was the first time the diagnosis code appeared in the patient's record. Any questions? Go ahead.
I'm just trying to make sure I totally understand that. So the first time the diagnosis code appears in the record, you're trying to take from that whether or not it was an appropriate place for primary care?
No, just whether or not primary care was in fact the first contact for that diagnosis. And then it would be going into the literature and seeing, okay, where do we have instances where primary care is perhaps not being utilized as much as it could be for that first contact, and thinking about which of those instances would we want to prioritize. So for example, perhaps it's diabetes or asthma or other chronic conditions, et cetera. But as I mentioned, I really think this can't just be a claims-based approach. It really needs to be working with the literature and with stakeholders to understand what are going to be those priority areas.
Okay, and so just to step back briefly, we had a comment from Sally and Alborn. Thank you. We'll go back and take a look at that to see if we come back at the next meeting with some changes to this particular line item on on personnel touches. But perhaps Dr. Bernstein, you could clarify for the group your thinking in the comment that you just added.
Well, it is backtracking. The question is whether the measure of the actual level of the provider and the consistency of an individual within contacts is less important, and probably contrary to the overall emphasis that the direction is it's a primary care team that provides the value of primary care. So both in importance and difficulty, we probably shouldn't, in my opinion, be emphasizing the individual nature of the contact. Therefore, data that does identify groups should serve the purpose.
That's a great point, Dr. Bernstein. And David, I think if you go to the next row, this is actually where this comes up.
So we'll slide down just momentarily. Manny, can you scroll? And while we're doing that, Trustee Knoll in the comments noted about the list of commonly performed primary care codes. Yeah, we have that. In fact, we can send a link to that later on today.
And so if we go just one more down to instead of individual provider, assigned care team. Yeah. And I agree absolutely with you, Dr. Bernstein, that where we really want to go is understanding the role of the care team. And this can be a little bit challenging sometimes in claims because, as you know, not all members of the care team always bill on their own, right? And so there may be other members of the care team that actually provided the service. That being said, what we can look and see is the proportion of services that are delivered by individuals that are within the same organization. So, you know, whether that is the primary care provider, the nurse practitioner, et cetera.
And Mary Jo, this is Sally. I think it also depends on where, you know, the place where the care is delivered. Because, you know, it differs for, say, an FQHC or a hospital clinic versus a private practice practitioner.
That's so true. And that's why I think it's really important to think of FQHCs. So if you look in the data, FQHCs can be both a taxonomy as well as a place of service code, and really sort of using all those available data fields to understand which organization was providing that service and how that occurred. It's a great point.
Yeah, the model makes a difference.
Indeed.
Indeed.
Other comments before we move on? Okay.
All right, so this next one looks at timeline to first contact. And here we are proposing using those survey results. I know that the survey results may not be most appropriate for the pediatric population. We can look more into that. The CAP survey is used, though, by a lot of commercial carriers as well as Medicare. I think what you'll see here is that this really asks from the patient perspective whether or not care was provided as soon as the patient needed it. Now, of course, the patient may not have a good understanding of their immediate clinical need, whether or not it's urgent, emergent, et cetera. But this question does try to ask the patient from his or her perspective whether or not they received care as quickly as needed, whether or not they could get in as quickly as needed into the office for an appointment.
Okay, reactions from the group?
I would just comment, it may not be accessible data, but you know, with more and more online scheduling systems being available, those systems do measure availability and typical times between requests and appointments filled. I don't know if that would ever be accessible data, but the data is accumulating in that sense.
Yeah, patient schedulers, you know, practice management systems are pretty valuable and are more and more becoming intertwined with the EHR records. So it is something we need to keep in mind.
I will.
Well, and I think this is Sally. I think in line with that is, you know, do we have some standards against which this is measured? Because of course you've got the patient subjectivity, number one. But I agree with Dr. Bernstein. I mean, beginning to look at online scheduling systems, we've been trying to track this kind of stuff for years to measure and evaluate access. And we don't have any real good methodology that isn't so highly manual and resource intensive that it makes it almost worth nil. But the one thing we struggle with is the subjectivity and then actual standards.
Yeah, that's very true.
You know, some people say, well, the third next appointment when? This week, next week, next month?
Right.
This is really a you know, one of the great conundrums I think that we have in primary care.
I see some comments in the chat, and I think they reflect largely the discussion here. Are there any other comments before we continue onward?
David, I might just a quick one on this. So what I'm going to propose is certainly not a solution, but it is the way another state tries to answer this question. And so in Delaware, they do a provider survey each year in which they ask providers what is the average number of days for new and existing patients. I believe those are the two questions to get an appointment. Again, it's certainly not perfect. It's an aggregate, it's survey, not everybody responds, all the reasons. And of course, really what should be the answer is a great question. I don't think we know, but happy to send that survey to the MHCC team if helpful.
Yeah, no, that's great. Please do. And again, we appreciate the comments. And I will just remind everyone that what we're doing is sort of the building blocks that Mary Jo, we hear her talk about quite a bit on her support of this work. We'll get other opportunities. We are today just trying to get a bit of a sense for what the work group feels about these particular pillars, if you will. So thank you all for your comments. Dr. Bernstein, did you want to clarify your point for the group?
I just think with imperfect and limited mechanisms to measure this, it's going to be hard to get a sense of where are we now. But I think the best we might be able to do is measures that can indicate trends and progress over time without relying on the having a complete handle on the moment, if that makes any sense.
Very
Yes.
good. Okay, thank you. Mary Jo.
Yes, so the next set of operational elements are related to comprehensiveness. And so several of these are really looking within the claims to see what are some of the services that are being provided by primary care providers, and how does that vary? For example, in this first one, how does that vary across primary care providers? So for example, what we often hear in states is that some primary care providers are more likely to perform minor procedures than others. So that's just the example that I laid out there. So essentially, the rationale for this is that by looking at the services that are provided by primary care providers and how that varies across them, we can get a better sense of what does primary care look like in the state right now, and what might be opportunities to support primary care providers in expanding the scope of services that they offer.
Any reactions? Okay.
Dave, this is Sally. I just think also there needs to be, you need to define what you maybe different levels of what we mean by primary care. So in an FQHC, primary care includes OBGYN, behavioral health, somatic health, oral health, pharmacy, clinical pharmacy, whereas in a different setting, perhaps a hospital, clinic, or in a private practice, that differs. And then I've noticed, this is not scientific, there's some primary care docs have subspecialties, so end up seeing patients not for primary care as we typically do, but for infectious diseases, things like that.
Yeah, that's great. Thank you. And I see we're still getting some very good chats in the comments. So looking back to some of the other items that we talked about. So thank you all for that, and we appreciate it. We'll be looking closely at what's been provided. Anybody else for this particular item?
Sorry, this is Meta. I'm wondering if there's any judgment in this question. So like, is it better for primary care to be providing more services, or would we like primary care to be doing a better job of providing higher quality but fewer services. So like, I'm also a midwife, so do we want primary care doing the OBGYN arm, or would we rather that not be a primary care service? So it's sort of a similar question of defining primary care, but also wondering if we have opinions about that, or if we're just looking for data.
So I think it's a little of both at this stage, to be honest, because we don't know what we don't know, and feedback like that gives us something else to consider. At the moment, we have some pretty good data sources to consider, and maybe there are other sources as well. But we definitely want to capture the point that you noted, so we have a chance to go back and give this some more thought. It's a very good point.
Hey, David, it's Michael. Just want to announce that I'm here. I joined late. Apologize.
No worries. Thank you for joining, Dr. Barr.
No worries. And then on that last comment, I think during the prior call, I made some comments about sort of the very comment that was just made about sort of context matters when you ask these questions about range of services.
Yeah, indeed. Very good point. Thank you. Mary Jo?
Great. And I do think echoing what we've heard from the group, the first step in performing any of these analyses is defining primary care. And so more to come on that as well. The next one is related to the spectrum of population needs. And so this is essentially looking at, what are the diagnosis codes that we see primary care treating most frequently. MHCC has already been doing some of this work. And then looking at the literature and talking with stakeholders about what are some diagnoses that we think could be more frequently treated in a primary care setting. Similar to the last question and David's response, I think, and David, feel free to correct me, but I think this is similar in that we're both trying to get a sense of what is the current state, but also sort of facilitate a conversation around what we may want to see in the future.
Yeah, great point. Any comments as it relates to this one?
David, this is Sally. In addition to the, would we want to add also geography to this when I think of total cost of care and the area around perhaps where a hospital and partners are working? Should we be considering the spectrum of the population's need within the context of the geography?
Yeah, I think that it's good to note it, although I have to tell you, as I think about that quickly, I don't know a good source for that. I mean, it seems like it would be difficult. It's a great idea, but I feel like it would be difficult to do, but maybe it just needs to be thought about a bit more. But
David, I think, oh, go ahead, sorry.
No worries. We have Dr. Bernstein, but why don't you go ahead, Mary Jo, and then Dr. Bernstein.
I was just going to say quickly, I think one way that we could get at the geography is to look at the members' location, at least broadly, and maybe even assign them to something like rural versus urban, et cetera, because I think part of what we're hearing that is that the potential resources around the primary care practice can also influence the needs managed by the primary care practice.
Good point. Thank you. Dr. Bernstein.
Yeah, I think this is really a fundamental question in what we're trying to accomplish, because if our goal is to increase resources and use of primary care, what combination are we really looking for in terms of expanding access to primary care to more individuals versus and bringing in more care to the primary care setting because maybe it's more cost effective and higher quality than when done elsewhere. So this really is a fundamental issue that we should have a sense of.
Yeah, that's a good point. And several people have noted the ADI, and that's probably a very good way as well, but all good points.
Yeah, David, this is Nora. I would just add too, MAC is required to do a community needs assessment at a state level. Of course, we go down to the county level, and then each one of our centers also has community needs assessment. So there may be something to grab from that approach. And I believe there's a place in MDH, I can't remember the organizational level, but they have to do one as well as part of a HRSA requirement.
Good points. Thank you. And I just want to note that our executive director and chair, Mr. Stefan, has joined. Okay. I think Mary Jo, we're good to move on.
All right, great. So the next set of analyses look at trying to understand the depth and breadth of conditions that are managed by the primary care team. And I think this is very similar to what we were just talking about in terms of the spectrum of population needs and the services provided, questions just asked a little bit differently. And so a couple of examples of approaches that we looked at here included the CAPS question that asked patients, is this the provider that you usually see if you need a checkup or want advice, or if you get sick or hurt? This sort of comes at that same idea another way from the patient perspective is, does the patient view the primary care provider as the place that they usually go to when they have a problem? On the flip side, we've also laid out a few high-level chronic condition quality measures here that could also be used. So, for example, looking at the PQIs, the prevention quality indicators, which look at potentially avoidable admissions, looking also at acute hospitalization and ED utilization, and then looking at some of the more common chronic condition measures, the blood pressure measure, the standard diabetes measures, et cetera. So I'll stop there and get some input on those two.
Okay, any comments? Okay, I'm not seeing any. Again, this isn't our only opportunity. If comments come as we progress forward, you can certainly use the chat feature, or when we talk again on the next meeting, we can come back to some of your all's thoughts as well. Mary Jo.
All right. And so then the next one is sort of similar, looking at essentially developing episodes of chronic condition care, looking at how often these episodes are managed by primary care providers versus specialists, and does the data show differences in cost or use of services or outcomes? I think that, while this is really interesting, at least to me, I think it is important to also remember that individuals with more complex chronic conditions may be more likely to seek care of a specialist. And so, as with always, we have to be careful about comparing populations to each other. At the same time, would love to get the group's thoughts on whether or not this would be a valuable exercise.
Reactions? Dr. Barr.
There's a dilemma a little bit here when it comes to using coding or billing information, because there's incentive for, especially under Medicare, for primary care doctors to be coding diagnoses for hierarchical coding and such, even when the majority of care for that condition may not be occurring there. So I think there's a lot of distortions, it would seem like, by using billing data to measure this.
And Dr. Bernstein, did you have a secondary thought about a better approach?
No.
Very fair.
Yes, indeed. Dr. Barr, could I pull you into this a bit?
I'm just trying to catch up.
We can always come back if you're not prepared.
David, this is Nora again. Can I just add that, so I know we talked about it a little bit before because it's part of the PQIs, but the ambulatory sensitive conditions, that seems like it would give us a good look into what, to what we're trying to capture for this particular one, I think. I don't know if you need the Prometheus tool to do that, as opposed to, I thought ambulatory sensitive conditions were tracked within CRIS, but I may be wrong.
So we do have the ambulatory care sensitive conditions, the PQIs listed. I think it's 2 rows above.
Yeah.
And agree with you. Yep. Right over there. If you scroll over, I believe we have those there. Yep, there they are. But I agree with you. A great set of measures, especially a great set of measures to look at primary care across a large population, doesn't work as well when you're sort of comparing primary care practices to each other, but across a population, it can be very effective. And so we do have those there, and just wanted to give folks a few different sort of approaches or flavors to consider.
Okay, thank you, though, Nora. Very good comments. Anyone else?
So David, since you looped me in, I'm looking at the rationale in that column, so it's over a little bit to the right on the screen.
Sure. Thank you.
Leaving aside the complexity that I think Dr. Bernstein raised in terms of sort of all that, I would say, again, back to that context we were having earlier, this says conform conditions which primary care providers are best positioned to manage. I would say, or specialists are best positioned to manage, right? I think it's really important we recognize that it's not always in the best interest of the patient to get treated by the primary care provider or primary care clinician. I don't like to use the word provider, because that's, and the costs may actually be less when you get the specialists involved, especially in certain things. So I think we need to make sure we leave that door open.
Yes, very good. We will make sure that it gets noted in the comments. Thank you. Anybody else before we continue onward? Okay, Mary Jo.
All right, excellent. So the next 3 examples of approaches relate to integrated behavioral health. And you're going to see these pop up again a couple of times throughout the remainder of the spreadsheet as questions regarding integrated behavioral health come up a few different ways. So the first one is using quality metrics to measure primary care providers' performance on a couple of standardized measures of quality related to behavioral health. So somewhat for example only, but I've included here follow-up after emergency department visit for a mental illness and also risk of continued opioid use. These are 2 that are used. You could also include ones on depression, treatment, etc. But the first is really just thinking about it from a quality measure perspective. The next is thinking about it from and actually the next 2 are really thinking about it from a utilization perspective. So they're in row 18, looking at the utilization of psychiatric collaborative care codes and other integrated behavioral health codes. And then the next looking at the utilization of recommended behavioral health screenings. And David, I'll stop there. I think we're starting to get some comments in the chat.
Yeah, we're getting some good feedback here. Why don't we start with Dr. Bernstein and his comments, if you can clarify a bit, and then Teresa will turn to you.
It just, it's come up a few times. How do we measure what's being done by the primary care team that may not be just visits with the doctor or nurse practitioner, and if adequately used, but they're probably underused, the care coordination, collaborative care, transitional care really can be a reflection of that as well.
Yes, indeed. Thank you for that. Dr. Teresa. And you have us on mute, so she may not be able to comment. Does anyone want to respond from the work group to Dr. Bernstein's point?
I think the team, I'm sorry, go ahead, sorry.
No, go ahead, Dr. Barr.
Building on what Dr. Bernstein said, I think lower on the screen is the rates of social drivers of health screening. I think that's also part of what the team could be doing to support sort of all the issues we know that relate to chronic conditions that are related, not related to actual the care provision, but to identifying them and then helping to close those gaps. So health-related social risk needs screening would be really important as part of this, I think.
Good point. Thank you. Okay, why don't we turn back to Mary Jo, and just to be aware of time, we have about 6 minutes and we'll then start to have the next step and wind down piece, but just to give everyone a time check.
Sure, that sounds great, David. So the next one is looking next one is the rates of SCOH screening there. And so want to just give everyone a chance if there's any additional comments on that, and then we can go to links between primary care and tertiary and secondary care, which I think is next. Am I right? Yep.
That's correct.
Quick question: does the program recommend a specific tool to be used for the screening? I apologize, I jumped. It looked like it was under the integrated behavioral health row. So Mary Jo, sorry if I went to SDOH.
Oh, no problem at all. No, well, David, I don't believe at this time MHCC has any preference on SDOH screening tools. Is that correct?
Yeah, that's correct. We're open to ideas. Again, this is just the data collecting stage. So any idea is a good idea.
I recommend having one.
Yeah.
It's a good idea.
There you go.
Yeah.
All right, I'm going to go ahead and jump to links between primary care and secondary and tertiary levels of care. So what we've included here is using claims data to look at readmission rates. I love the idea, by the way, in the chat to incorporate, how often are LCSWs billing. That's interesting. We can take a look at that. And you'll see here that we just link to the measure. Thoughts on this or other measures or approaches that you think we should consider?
Reactions from the group.
Plan all-cause readmission is a good one, but obviously any transitional care measure that's been approved, you might want to kind of consider because that doesn't cover everything. You might think about some structural things about whether agreements between specialists and others are intact, or whether there's established data flow between the secondary, tertiary levels of care and the practices, and those types of things. So less necessarily around outcomes, sometimes around structure and process that's in place.
Good point.
Agreed.
Okay, I don't see anyone else with hands
Maybe
raised.
referral patterns between.
Yeah, I mean, if you want to get fancy, it's are there pre-consultation or pre-referral sort of engagements between specialists and primary care, or even between the hospital emergency department and the referring clinician if a patient's in the office. All those engagements taking place, so the information is shared, the needs are identified, and the appropriate care delivered.
Thank you, Dr. Marsteller. That was a good point. Okay, thank you, Dr. Barr. So time for one more, Mary Jo.
Yes, and so, I think we've actually looked at, in some ways, all of the different examples of approaches except for two, because some of them are, or maybe three, because some of them are sort of repeated throughout to answer various questions. So I wonder if we want to jump to continuity real quickly and tee those up for the group.
Sure. Well, let's give it a try.
All right. So the first is the level of continuity. And so this is just essentially, again, asking that same question around, what percentage of the visits are with members of the same care team or working for the same organization. The next one is using advanced planning CPT codes to look at the use of advanced care planning occurring in the primary care practice. I will just stop there for a second.
And fear not, folks, I know we're moving a little fast as we get close to the end, but we can come back to this, or at the same time, we can collect thoughts in between this meeting and the next. So
absolutely.
Any reactions to what you see here?
I just keep getting drawn back to a paper by Ann O'Malley and Gene Rich a few years ago when they started to do some of this background methodology about looking at comprehensiveness and sort of continuity. Mary Jo, you're probably familiar with it, or I'm sure our colleague Berenson will help us with that. But anyway, I just think that could apply to some of these. I'm not sure whether it's operational or not, but some of the concepts would.
Happy to take a look at it again and see how we can think about it in this context.
Okay.
I'm not totally clear on how advanced care planning fits under continuity. But
Sure. So that was one of the operational elements that was included in the questions that were sent out. I think the idea here is that, essentially getting ready for what can be a challenging and complex time, and making sure that that is documented and you have the input of the patient. But David or Melanie, please feel free to jump in there.
I think that's well put.
Mary Jo, Sally, can you describe a little bit the continuity should be based on physician-led teams and how that fits with level of continuity, physician, nurse practitioner, et cetera?
Sure. So I think that the continuity should be based on physician-led teams was, I believe, a comment that was received on the questions that were sent out. I don't think that that was necessarily an operational element that was originally listed. If I'm remembering correctly, that was one that someone added. I think, though, that they're really looking at the same information, which is, what are the proportion of an individual's primary care services that are being delivered by clinicians that work together or in the same organization. I think this is a really important question for us to be asking as we move to more care-based teams. But as I noted earlier, one of the challenges when we try to assess this in claims is that some members of the care team are not always represented in claims, or at least not all the care that they've provided.
So we are pressed against time. We'll take the next 60 seconds to kind of wind down. And again, noting our chair had joined midstream, we'll invite our executive director, Mr. Stefan, to make any remarks, and then we'll sort of close it up.
Thank you, David. I appreciate everyone getting on this call for the last hour. I came in about 20 minutes to 1, so I missed some of the comments, but when I was here, I think the thoughtfulness of the comments demonstrates to me that we're taking this very seriously. I feel a little bit like Dr. Barr catching up, but I know we have a couple more of these scheduled, and I look forward to having my schedule better aligned with this particular meeting because it's extremely important. And again, thank you to all the attendees for participating.
Thank you. Melanie, do you want to wind this down?
Yes, thank you, David. So, our intent today was to obviously go through this sheet. And so that's what we will continue to do next time, is we'll continue to walk through these similar to the way we did today. We do have a meeting set up for, hold on, I just had the date in my head, the 24th. Again, that one is from 1 to 2 versus from noon to 1. So if anyone has questions, please feel free to reach out to the team. We do have a, David, did you want us to send out that list of CPT codes to everyone? Okay, so we have a file of taxonomy codes, CPT codes, and other codes that we can send out to people to help us define more primary care. So we'll get that out to everyone. This meeting is recorded. It will be posted to the website, as well as a very high-level meeting summary.
Thank you all for your time. Have a great rest of the day and a great week. See you.
Thanks, everyone.
Thank you.